Good evening, everyone, and welcome to this webinar on the future training of non-technical skills for surgeons. NOTSS, and for most of you who have heard of NOTSS, you will know that this relates to the cognitive and social skills required for good surgery and for good surgeons, and in fact, it's very good for the whole team. We're very grateful to the college for all their webinar series that has gone on over the last few weeks. And I think they've brought a lot of people together for some great educational activity. And I'd like to thank the college as well for all their help in relation to the college hotel, which has provided a huge number of breakfasts free of charge to healthcare workers who've had trouble getting home or who are avoiding people who are self-isolating. So thank you very much to the college and the president, Mike Griffin. We'll move forward with today's webinar, and I will introduce the different speakers as we go ahead. We've got a lot of speakers, and we're all going to be cut to 5 minutes each, and I'm going to cut everybody at 5 minutes. So you'll see a little bit of communication, teamwork, and situation awareness going on as the clock ticks on. So NOTSS training can be put into context in relation to the GMCs, Generic Professional Capabilities Framework. See here that in Domain 6, the key areas that need to be focused on in our training are areas around human factors principles and non-technical skills. Academy of Medical Royal Colleges at the beginning of this year took this forward, and we had a scheduled meeting with them which was cancelled because of to how this training can take place in all curricula for all specialties. Now, it's fine for surgeons because we are already doing it, but it's not the case for other specialties, and we may discuss that during the questions towards the end of this webinar. At the present time, the college have been running NOTSS for consultant trainers and for senior trainees since 2006, and they've been developed by Steve Yule, who is on our panel this evening. And welcome back, Steve, from Boston, to the Chair of Behavioural Sciences in Edinburgh. We've now run many NOTSS courses for trainees in the UK, and these have been run on a regional basis, and we have several of those faculty speaking tonight to tell us about how these regional training courses are undertaken. And of course, that will answer some of the GMC's requirements for training of trainees. There's a lot of NOTSS material on the college website, freely available to everybody. Running NOTSS courses outside the UK for many years now, initially in Australasia, but increasingly in other countries. Malaysia have just taken this on board and are running their own NOTSS courses. America have been running them while Steve was over in Boston. And we've also been running regular courses in Malta and Nepal. And Walker, who's on our group here, along with Jeremy Ward, have run those, but also in Palestine, Oman, and Qatar. We've recently been approached by the Philippines, Sri Lanka, Thailand, Spain, South America, and Canada to help them set up NOTSS courses. And I think we may discuss some of that at the end. They're currently developing an online module for NOTSS so that in physical distancing areas where we have difficulty getting everybody together or remote areas, we can run the NOTSS courses by distant modules. We're running team training courses, so that safety in numbers team training, as you see here, the SAINT courses developed by Craig McElhenney, and they're run through the college. And we've just produced the NOTSS Handbook version 2, which you can see at the bottom of the screen here, and that will be first used in Malaysia, who are running the first NOTSS course after the lockdown in August. So I hope that one goes well. So without further ado, I'm going to move on, and I'm going to introduce Rosie Darwood, who's a vascular surgeon in Leeds, and she's going to talk about setting up NOTSS courses for trainees. So welcome, Rosie.
Thank you very much, and thank you for asking me to speak on this webinar. Next slide, please. So the philosophy for running NOTSS courses was fourfold, really, running regional courses. I've been running regional courses for consultants and trainees in Yorkshire since 2017. And we wanted to provide the NOTSS courses with local credibility so that when delegates came on the course, they may have contact with faculty they knew or had further contact with, to facilitate them taking the skills and ideas from the NOTSS course back into their working environment. The second thing that we wanted to do is reduce the costs, and by reducing the cost to the faculty in terms of travel and accommodation, we could then pass those reduced costs on to the delegates in terms of the course cost, and sometimes with a reduction in the venue cost as well. Thirdly, we wanted to reduce the costs to the environment and lower the carbon footprint of the courses by, again, reducing the travel costs and making it more sustainable. And finally, we hoped that by providing a course which was open to trainees from across the region, we'd get trainees from multiple specialities. As trainees get further through their training, they spend more and more time within their own speciality, and the opportunity for interaction between trainees from different specialities can be really valuable. And indeed, the first consultant course we ran, we had a range of consultants from different specialties, including an interventional radiologist who's gone on to become one of our faculty. Next slide, please. So moving on to the practicalities of the course. The first thing we had to do was find a venue, and actually that was reasonably straightforward. The NOTSS course requires decent audio-visual equipment and a voting system which is done via a mobile phone app which people download beforehand. What's really important is that the venue is a suitable place for having interaction and small group discussion. So I think it's vital really to hold it in an area where you can do that, and a lecture theatre just doesn't offer the same opportunities from that point of view. The second thing was the people that we needed. And so the very first course I ran was designed for consultants from Yorkshire in order to train up faculty. It was a fantastic course, really fun to teach on. All the trainers wanted to be there, and 6 of them have gone on to teach on regional courses. I have to say the first course that we ran solo, I was a little apprehensive about, and I've been absolutely bowled over by the quality of the local faculty and the breadth and depth of knowledge which they've brought with them. Some of you may know Shireen Mackenzie here, who's a breast surgeon, and James Tomlinson, who's a spinal surgeon from Sheffield, and they were our first 2 local faculty. Although we've aimed the course at regional trainees, we've not closed it to international trainees, and the consultant course we run has been taken up by people as far away as Israel and Ireland. But the trainee course, we've aimed at higher trainees, but again, not exclusively, so more junior trainees from ST3 and above have also taken part. And finally, the cost. So as I mentioned earlier, we were able to reduce the cost of the course, and we worked with the deanery, who initially funded the course directly, but now the trainees claim back. But I think it's very important that those deanery trainees are able to get the course funded. So next slide, please. What was the outcome of the course? I won't apologise for this rather long quote, as I appreciate the trainee putting the effort into it. So, an interactive, thought-provoking course which has richly improved my knowledge and will change my clinical practice, run by enthusiastic and extremely knowledgeable faculty. The second quote was from a pre-CCT trainee who felt it should be mandatory for all trainees to undergo the course, something we've discussed previously, and a more junior trainee interestingly said they anticipated doing the course regularly every couple of years or so, which is not something we've adopted, but is something that may be referred to later. And we were pleased to see that they enjoyed the multidisciplinary nature of the course. And actually, the final comment is from our consultant, who said it was possibly the most interactive course that they'd been on. And certainly, trainees mentioned that they learnt a lot from the other delegates as well as from the faculty. So where do we go now? COVID is clearly providing us with a significant challenge in terms of running this course, which is so dependent on interaction and discussion, which, as we all know, is never quite the same on Zoom. So we're looking at options of running smaller socially distanced courses, or of how we might deliver this in a blended format. And I thought in these challenging times it was appropriate to leave you with this quote from Martin Luther King. And I would suggest that our dream is not only to be able to provide NOTSS courses that are accessible across the country, but for the NOTSS culture to be adopted into theatres and surgical departments across the country. Thank you.
Much, Rosie. Well, that's a great start, and let's see if we can continue the dream. It's a great pleasure to welcome Mike Bradburn to give us the next talk. And he was the first of the NOTSS faculty to set up the regional trainee NOTSS courses in the northeast of England. And so Mike's going to tell us a little bit about the experience and what they've done so far and how many trainees they've trained. Welcome, Mike.
So thank you very much, Simon. Thank you for asking me to talk, and thank you for a great introduction, Rosie. So a history lesson. Health Education England North East, or HENE, is an acronym you'll be hearing quite a bit. So how did we start on this journey? 2010, HENE organised a human factors course, and I went along to that, and it was provided by A-Trainability. Now, I don't know if any of you have come across this, but it's a group essentially of pilots who are putting out the concepts of human factors, particularly in healthcare. It was a brilliant course, but it was very aviation-centred, which irritated me slightly. But I kept on with that theme. The following year, I took 8 delegates from cross-surgical specialties up to what was then the 2-day NOTSS course up in Edinburgh. We were essentially blown away by it. All of us came back extremely enthusiastic, but didn't then translate that into running NOTSS courses locally. What I did was initially ran a sort of a mixed human factors Calgary-Cambridge communication skills course for a CT1 trainees. But in the middle of that, and I think 2014, I got recruited into the NOTSS faculty. And the idea came to me then that why couldn't we run a NOTSS course? I ran this past the college and got very marked encouragement to be able to do that. Although I was worried that I was taking what was a really good Edinburgh product, and I wanted to make sure that we delivered it in the same quality manner. So we ran our first, in inverted commas, franchise NOTSS course for the full range of trainees from CT1 to ST8, using the Edinburgh materials and Edinburgh quality control, namely Simon, who came down and observed our first 2 courses and said, happy for you guys to go. The practicalities for each of the courses, we had 25 delegates. I used some of our initial 8 people who'd been up on the 2-day NOTSS course, but I wanted to grow our local faculty in a different way to what Rosie did. So I didn't run a course for purely consultants, but got consultants along targeted because they were interested as observers. And from that, I recruited people who were interested in helping us deliver the course later on. So next slide, please, Simon. So what have we done since? I've said up till 2019 because COVID has rather truncated what we've done since that time. But we've run 2 courses per year. Now you'll notice there that I said ST3+. We started providing different things for the CT1 trainees because I think a lot of the value in the NOTSS course is getting people to reflect on what they've seen, what they've done, and the mistakes that they've made. And we tended to find that the core trainees, whilst extremely enthusiastic, did not have the depth of experience within the theatre environment truly to benefit from that. That's something you may discuss, we may discuss later on. So since 2016, we've had 150 of our trainees through, and we've had 15 consultant observers from a variety of specialties, and indeed some non-surgical specialties, and I'll talk about that later on as well. For the core trainees, we borrowed Alistair Geraghty's course, the Managing Surgical Crisis course, which is a very much a mini NOTSS course, but with some more practical simulation and discussion of the problems that we put them into, applying the NOTSS principles. And that's worked very well. So our faculty has now expanded. We've got 16 regulars across a wide range of specialties, and you'll see those documented there. Next slide, please, Simon. So where do we go next? Well, I said we've had some non-surgeons involved, and we had some gastroenterologists who said this is absolutely amazing. Gastroenterology and the endoscopy room environment is just the same as theatres. Can you do as a NOTSS course? Well, I said, well, not really, but I can amend some of the concepts. And they actually produced their own NOTSS video of things going wrong within the endoscopy environment, which we now use. Ophthalmology, which I appreciate is a surgical specialty, but it wasn't within my school. They're now on board as well, although wanting us to deliver the courses from them. We expanded with the able help of Andy Miller to Malta, and our faculty's now trained 100 of the trainees and consultants in Malta. Interesting to reflect on that because they took quite a different approach and had not just surgical specialties. So we had the anaesthetists in there as well, radiologists, and actually I think it produced a lot of richer discussion and very, very interesting course to run. Where next? I still have harder to access specialties. I've had no trainees yet coming from neurosurgery and only one from cardiothoracic surgery. And I'm finding it harder to penetrate into those training programs. Thank you, Simon.
Thank you for leading the way in the franchising of the NOTSS courses, which have now taken place in a lot of different regions of the UK and, of course, overseas. We're going to move now to comments. I've probably gone to one step too far, so we'll stop there. Andy Miller runs these courses in Leicester. He's locked down at the minute. He's in his house. He can't get out. And he's going to give some comments about where we are in running these courses. And then Jeremy Ward from Preston is going to make some comments, and then we'll move further on. Just to say, we're going to take questions at the end of all the talks, so think about things at the minute, and you can post your questions on the Q&A section of your screen, and we'll try and pick up as many questions as we can. So, Andy, any comments so far?
So thank you very much, Simon, and thanks very much for the kind invite to talk this evening. I think that one of the biggest comments, and is obviously the point made by Rosie and Mike, is engagement of the local deanery. Although that would prove, or has proved to me, and I think Jeremy would echo it, quite challenging to get the deanery on board. Once they're on board, it's very, very worthwhile. And I think in parallel with that, engaging the head of school is also an essential component for you to set these courses up. In terms of faculty, in Leicester, similar to Mike, in that I ran the courses with your help and Jeremy Ward's help and Jeremy Bannister's help, and got my consultant colleagues to come and observe. And the sort of local faculty development we had in Leicester was down to like-minded individuals. At the present time, we are all general surgeons or vascular surgeons. Similar point that I would make as Mike: neurosurgery, cardiothoracic surgery, not hugely engaged with the process. The orthopaedic team are very, very keen and have come and observed, but are very keen for me to run their courses for them. Not too keen on becoming faculty, which was an interesting approach for orthopaedics. My experience outside Leicester has been very keen, very interested, and I've certainly helped set up some courses in Portsmouth with several orthopods on the developing faculty. I would echo, final point before handing over to Jeremy, the sort of the longitudinal approach to training. I see one of the questions has raised the point of, is the NOTSS course something that should be repeated? And my experience would be there are sort of two cohorts of trainees: the early years trainees who don't, by the nature of their training, have that much clinical experience, and therefore it's more of a delivering information type of course, compared with the ST7s, 8s and the consultants who are also trainees but have a wealth of clinical experience and therefore can be slightly more engaged in the discussions. So I look forward to people's thoughts on that. And I think that would be my comments so far. And Jeremy, I think we'll have a few more.
Thank you very much, Andy. Jeremy, would you like to give some comments at this stage? Jeremy's a consultant surgeon in Preston.
Thank you, Simon. Good evening, everybody. So just briefly, in the northwest of England, where I work in Lancashire, we've been running sort of what initially standalone NOTSS courses for consultants and very senior post-CCT trainees over the last couple of years. And we moved on to plan regular NOTSS courses for our early ST trainees across a whole range of surgical specialties. And as Andy says, the key to that has been the engagement of our head of school and our associate head of school, actually, who's in charge of simulation, who has come on one of our later courses and come onto the local faculty. So engagement of the School of Surgery and local enthusiasts across a range of specialties has helped us in our plans to set up our courses for trainees. And we, at the end of last year, beginning of this year, we set up we planned 4 NOTSS courses over the course of the year for all the surgical specialty STs coming through, together with 2 consultant courses for educational supervisors who are interested in further joining the faculty. Then COVID-19 struck, and that was all kiboshed, so it's all had to be put back. And we're now looking at setting it up later in the year as things die down. So there's been a lot of work from a lot of local enthusiasts, and I have to say we've had good involvement across the range of surgical specialties, which I think is important. One thing we have been discussing, and I think it's for further discussion, I guess, as we move forward, is remote learning. You know, we're all doing some online teaching now. I think and the question is, clearly there's a lot of face-to-face interaction in NOTSS courses with a lot of interaction. Is what can we do with remote teaching? There's certainly things to be learned when you're delivering courses remotely, such as changing the lecture side to short, snappy lectures, having facilitators to help coordinate questions and develop interaction. So that's maybe something else that we can discuss as we move forward. One other aspect, I think, with longitudinal training, I think that's being brought up later on, where we fit NOTSS at different stages of training. And we've talked about having a briefer introductory session for our core trainees rather than the full NOTSS course. But I guess that's something for further discussion as well. I think that's all I'd like to say at this stage, Simon.
Thank you very much, Jeremy. And I think those points are key areas about getting, and from Andy's comments too, about getting the deaneries involved and the funding and the encouragement from them, and also how we take things forward and whether it's longitudinal or not. So we'll move now to the next. It's a great pleasure to welcome Andy Garnham, who actually runs all the NOTSS courses for the trainees in West Midlands. But he's not going to talk on that at the moment. He's just going to talk about integrating NOTSS within vascular surgery and a research project that he's planning with the Vascular Society. So welcome to you, Andy.
So, Simon, thank you very much for the invitation to speak. And it's been a great privilege to introduce NOTSS in the West Midlands. But I think with the Vascular Society in mind, if we go to the next slide, we've been involved in what's quite exciting as the sort of first new surgical specialty in some years as we separated from general surgery. And that's given us the opportunity to institute something that we've called the Aspire programme, where all our trainees get a boot camp every year for each year of training. And that's been linked into the curriculum learning objectives for those years of training. So it's very well aligned to the curriculum. However, we have lots of simulation stations around endovascular and open surgical training. You can see there a station on endovascular measurement. I've clearly got somebody doing the teaching set while I'm relaxing in the corner. But those are very technical elements. We've also got some simulated scenarios that we do in a simulation lab. But all these elements of training contain non-technical skills. And I think we've seen with the COVID crisis that we've now actually moved a lot of this training that we've been doing through Aspire to an Aspire digital platform. So I think we've got opportunities within the individual specialty, and we've talked already tonight about how we integrate things longitudinally with our trainees. If we move to the next slide. So I think you alluded to earlier, Simon, that surgery is ahead of the game here with introducing non-technical skills. But clearly the GMC have caught up. And with the regulator now putting, as you can see there in its new General Professional Capabilities Framework, professional values and behaviour at the centre of our training, you can see where this is going. And indeed, that's affecting all domains around the table. But clearly, patient safety and quality improvement and leadership are both major domains within all the new curricula. So I think it is central to further training, really. So if we go to slide 3, where are we in vascular surgery? Well, you could see a very nice programme with annual boot camps, but actually what are we missing here with those non-technical skills? And this is by way of an advert. So Steve and I and the college have been working towards getting an educational fellow to look at a higher degree in non-technical skills to take this work forward. And what we want them to do is look at our current programme and see where the gaps are and where we can introduce in our Aspire programme non-technical elements with all of our work that we're doing already. So I liken the non-technical skills. You can see that I'm a sailor. You can teach people to pull on an individual rope or move the tiller. But really, surgery is like sailing, isn't it? The skipper needs not only to know what his team is doing, but be able to predict both what the wind is going to do, and you can see those boats might change direction at any time, and you need to know what the other teams within the hospital are going to do. So I think there's a great opportunity here to develop this within a particular surgical specialty, as we alluded to earlier, and actually integrate things, because this isn't a one-off hit. It's about how we integrate this with our specialty training. So I think I'm going to end there, and I think hopefully that will open this up to a bit of discussion and debate.
Well, thank you very much, Andy. I mean, I think you are ahead of the surgical game, because I'm not sure that there are similar training objectives in the other subspecialties of surgery. So well done. We'll look forward to seeing how that goes forward. So thank you very much, Andy. It's a great pleasure to welcome Ken Walker, Professor Ken Walker, who's a consultant general surgeon in Inverness. Now, Ken ran several of the webinars around simulation training over the last couple of months, and he's going to speak to us today on the boot camp and its relationship to NOTSS. So thank you very much, Ken.
Thanks, Simon. Can you hear me okay?
Yep.
Good. So, yeah, thanks for asking me to speak about how we've integrated NOTSS into surgical boot camps. Next slide, please. Which the Scottish Surgical Boot Camp is a 4-day induction course in the Skills Centre in Inverness, but it's for all the core surgical trainees in Scotland, the New Start CT1 core surgical trainees. And the programme, there's quite a lot in the programme, and it's about 50% technical skills, but the non-technical skills, next slide please, is a real theme through the camp. And I was reflecting earlier with Steve why that wasn't just about the skills, but it was a lot about the values that and the things we wanted to set about our community of practice from the start, as it were. So it starts with a couple of classroom sessions which are not exhaustive. We use the NOTSS Masterclass material, but of course we keep powder dry for trainees to come back to NOTSS Masterclasses later. And then we have a series of simulations of increasing complexity, tabletop prioritization exercise, some phone call exercises with communication skill traps, or opportunity for communication skills exercise. A quite complex ward round simulation where they have to establish a team and gather the right information in the face of distractions and communicate well, closed loop, and so on. And I agree with what Andy said earlier on about sometimes in CT1, the ward being a more familiar environment to work with than the theatre just yet, although NOTSS is validated really for the theatre. Some communication skills scenarios, and later on in the course, some sessions that touch on when it goes wrong and using NOTSS language throughout, including to discuss when and why things go wrong. And next slide, thanks. And interestingly, Simon, we've used your group's wants taxonomy actually for the ward, which is the categories and elements are very similar, but the outworkings are slightly different, and the order is slightly different, which is to do with the way that you approach teaching and managing a ward round. Next slide, thanks. We've spoken already about longitudinal strategies. Just to mention that this bootcamp forms the introductory part of a 2-year simulation strategy running through core surgical training, which, like others have said, is mapped to the curriculum and so on. And like the Northeast, we've actually adopted Alistair Geraghty's Managing Surgical Crisis course, which is really about recognising crisis and responding to startle and managing the team through that. Although sadly, because of COVID, the first cohort didn't actually get to do it this year, but we have promised we can bring them back to do that. And it's interesting to think about the themes that trainees have found particularly resonant in this and that they speak about during the simulations. A lot of talk about speaking up, about making sure that they have spoken up, about assertiveness. You know, actually it's interesting, there's a bit of there's a fear at the moment of being the stereotypical bolshy surgeon, and there's a desire to know what helpful and polite assertiveness and teamwork look like. There's in a very well motivated generation in that regard. There's lots of interest in the green box of finite cognitive capacity and the things that interfere with it. And so interesting themes. And next slide, thanks, Simon. I know Steve's going to talk about more international elements. Just to say, I count myself lucky to have been part of 2 teams, one in Nepal where I used to work. I got to join up with Kamal Ariel and Jeremy Ward and their Health Exchange Nepal team who've run some NOTSS alongside a technical skills course. And similarly, this Palestinian group of surgeons who have been running basic surgical skills courses. And there's a small group from the Edinburgh College who've partnered with them in a very fruitful partnership. And again, they're now introducing non-technical skills components. I think Omar Abdul Shafi is probably with us tonight in the audience. And it's interesting the themes that come out in discussion which might be subtly different. A lot of interest in flattening of hierarchy, and actually, interestingly, in both groups, there was an interest in moving this discussion on to consent, which is, of course, a little bit off this course and more into another work stream and course in the college, but really, really interesting discussion and very engaged. So that's it from me. Thanks, Simon. Except to say, if I can, just that I think I showed you that strategy, that 2-year strategy, and I do think that longitudinal strategies are the way to go.
I'm sure you're right. Thank you very much, Ken. And I think it's a great boot camp, and certainly our trainees who have been on it think it is wonderful. Particularly, they get a laparoscopic simulator to take away, and they can practice their laparoscopic procedure. So our final talk is Steve Yule. Steve Yule's recently taken up the chair of behavioural sciences in Edinburgh, and he's the director of non-technical skills at the College of Surgeons in Edinburgh, and will be taking forward and coordinating the various non-technical skills courses, development, research and assessment through the college and Edinburgh University. And Steve came from Harvard, and where he is or was the Associate Professor of Surgery. So good welcome to you tonight, Steve, and thank you very much for coming along. And we do enjoy your company in Edinburgh. So thank you.
Well, thank you, Simon. It's great to be here, and very inspiring to hear the other faculty talk about NOTSS initiatives around the globe. I'm going to talk about some work for a few minutes about work in Rwanda, and really on behalf of my collaborators here on the screen here, from the Brigham, from the program in global surgery and social change at Harvard Medical School. And there's some really exciting things here that we have implemented in Rwanda, and also some learnings that I think we can take back to that might inform non-technical skills initiatives across the globe, not just in sub-Saharan Africa. So next slide, please, Simon. I'll tell you a little bit about what the course is like and what we've done in the past year in Rwanda. And this is funded by the college and Johnson & Johnson as well. So we're very grateful to their support, for which this would not be possible to actually implement. And the aim here was to do something quite novel, but to do something that's also lasting. And so here we have a traditional NOTSS course, which has been run for several years in different iterations, sometimes as part of the COSEXA annual conference, the College of Surgeons of East and Southern Africa. And then we took that course, made a one-day course, and did a few innovative things that I'll tell you about. The first is a real focus on training the trainer here. So trying to empower some local faculty, like you've heard around the UK, to deliver this. I think that's really important. It means that the course is run and discussed in the local language, with local examples. People have credibility because they're teaching their peers or surgeons who are familiar. But also teaching the faculty to be able to train the course at a high level of quality is also really important. So those trainer courses are essential. So we did this, ran a big trainer course. We actually integrated NOTSS here with a technical skills course. So you can see at the top of the screen it says NOTSS REST, which is not a song title or an instruction, but REST stands for Rwandan Essential Surgical Training. And what that actually means is that day one is spent in the classroom, learning the NOTSS principles, situational awareness, decision-making, leadership, teamwork, with videos filmed in Rwanda. So the context looks familiar, has the same resource level. And then day two, actually the same cohort are then followed into the operating theatres, and they're observed using NOTSS in clinical practice, in the ORs, in the theatres, and then some debriefing and feedback after real procedures. And that integration of technical and non-technical, I think, is a really exciting way forward for this, because non-technical skills, as you know, do not exist in a vacuum. Some other parts of the innovation here are, we're really interested, you can see in the middle here, telecoaching and monitoring and evaluation. That's what M&E stands for. And as we were implementing these courses in district hospitals, taking it away from the main centres around the country in Rwanda, we actually taught 4 in district hospitals with people who provide surgery in those hospitals who are not necessarily always surgeons either. So trying to look at the reality of the work that's done and to train providers at the front line in these non-technical skills was really important. But the telecoaching and some follow-up actually speaks a little to the longitudinal discussions that we've had today so far this evening, using WhatsApp groups to keep delegates engaged. And we actually had some WhatsApp scenarios after the course that were sort of drip fed by faculty each week. So the delegates kept discussing vignettes or real surgical cases on WhatsApp and applying some of the NOTSS terminology. And this was really pioneered by Ejid Abahuji, who you'll either know or come to know as the surgeon in Rwanda, and with us in Boston, now at Northwestern University in Chicago, who's really been pioneering these use of new technology to follow up participants. And then we were interested in studying some of the barriers to implementation. We know it's not easy. We've heard some of the barriers just now. And so we're doing some follow-up interviews and surveys with participants to understand, okay, what have you learned on the course? What would you like to take into the operating theatre? And what are the barriers, systemic, cultural, resource level, that actually mean that it's difficult to implement some of these non-technical skills at the front line? And then some of the telecoaching, I think, is a real area we could work on, especially in COVID, but actually especially for rural and remote communities, especially for scaling up this kind of education, and for not relying on a one-time only course, but to actually have some continual engagement, lifelong learning, if you like, with participants. That's going to take resources. It's going to take faculty who know what they're doing, but it's also going to take some infrastructure to be able to either virtually or in person coach surgeons and teams. Next slide, please, Simon. And this just shows you a timeline here. If you can click at the screen, Simon. It shows you a timeline of what we did over the past year, focusing on these education activities there, but also monitoring and evaluation. And that's important to highlight, because it's one thing to run these courses and disseminate them. That's really important. It's also really important to gather some data, understand from the user's perspective what the outcomes were, to understand, did it make a difference? Did we teach the right things? Did it make an impact on your behavior, on potentially educational and maybe even clinical outcomes in the operating theatre or for patients afterwards? And that's really important to be able to gather those data, and we have to think strategically about how to do that. Next slide, please. We learned several things as part of this that I think are not unique to Rwanda, although definitely the work was done there, but would be applicable in other parts of sub-Saharan Africa and also around the world. The first, we know that context matters, but having simulation videos filmed with Rwandan OR teams is really important. Team training, and one of the great innovations here that we can talk more about is we've taken a course that's really for surgeons, NOTSS, and expanded it to include the people who provide surgery and the multidisciplinary team, and anesthesiologists, obstetricians, nurses, all levels of training. And I think this is a huge area now that we could provide some leadership in terms of breaking down silos. It's very important to have individual skills training for those groups, but at the team level, this is where it all happens. This is where we're going to make a big difference to careers and to patients' lives. Empowerment through the faculty development is really important. Give people the chance to champion patient safety. And also the human factors. We know non-technical skills is part of human factors, but they're not synonymous terms, and we have to understand the institutional and systemic factors that can allow us to implement NOTSS and be successful at doing that. Final slide, please. Here are a few of the future directions. Be really excited to hear your perspective on these. So they're grouped in 4 groups here. So implementation, thinking about running these courses at a hospital level with a multidisciplinary group, having some kind of contextual assessment tool to be able to understand where what conditions need to be met to be successful? Can we understand the context first rather than provide a one-size-fits-all course? In terms of integration, I think integrating with technical skills courses, we've heard a few points on those today already. I think that's really important for this. And then also thinking about quality improvement and surgical safety, partnering with those. The third is adaptability. Again, if we take this to sub-Saharan Africa, and there are lots of different surgical societies there to be able to link with, and it has to be adaptable and fit with the culture of those societies. It has to be co-sponsored by them. We need to be able to engage faculty there, and that might force us to change how we deliver these courses in order to have maximal input. And then also online, we've talked a little now. COVID has helped force the hand a little here, but blended learning, having some interactive training materials, potentially doing some of the learning online at your own pace before coming to a group course would be a great way of doing this. And then also there's opportunities to support faculty and instructors in their accreditation and coaching them to be successful. And so thanks, Simon, but that's a brief overview of the last year's work in Rwanda and where we would like to go with this.
Thank you very much, Steve, and thank you to all the speakers. We've got plenty of time for questions now. I've been looking on I'm going to stop sharing the screen, and we've got questions, if I can just see where they all are. So, and I think all the faculty will be looking at that as well. Various questions about should we be integrating non-medical and medical staff together, the theatre teams and so on. And I think probably we could say immediately that team training have been developing over the last few years is surely one of the main things in the future that we should all be part of. So I think the answer to several people who've asked about that, yes, team training, a lot of that will revolve around getting faculty and training the faculty. So certainly one of the issues. Another question that came up was talking about how can you do NOTSS training if you're not in real time and discussion. And I know that Andy, you were going to answer that question. From Simon Toe, who runs NOTSS courses down in Portsmouth and Southampton. So thank you, Simon, for that. Andy, what are your comments about, we're trying to develop an online module and Steve and I are working on it at the moment, but do you think we can run NOTSS courses if we're not all together in the same area that Rosie was talking about, interactive discussion?
Is that to me, Simon, Andy Miller or Andy Garnham?
Sorry, Andy Miller, because I knew that you'd replied on the screen. So to you, please.
Yeah. I think it will be difficult. I think the COVID pandemic has given a fantastic opportunity for innovation, and a lot of online courses and teaching in the college has done an awful lot with webinars over the last few months. I think when you're running a NOTSS course, obviously it's a full day course, and it does involve an awful lot of interaction, a lot of videos and scenarios, and I think personally from a lot of the courses I've run and the feedback, it's the interaction, the discussion, and the facilitation of the discussion that is what a lot of the trainees enjoy. I think it would be impossible to try and transpose that into a sort of an 8-hour Zoom. I think we'd all die of either boredom or pressure sores or something. So I think trying to modulate it or split it up into modules, I think, which is what you and Steve have been looking at, I think is probably going to be the only way to go. But my concern is that you will lose some of that spontaneity looking at a computer screen to try and interact with some of the delegates.
So we'll feed back when we've trialed it out. We've done one module so far. We're going to do another one shortly. But I think that's one of the issues that we're worried about. We've had a question from David Large talking about should NOTSS assessment be required for everybody? Well, NOTSS assessment is required, as it's part of the GMC, and the Academy of Royal Colleges are working on it. And there is an on the ISCP website, there is a non-technical skills workplace-based assessment, but it's had trouble getting through the final changes to the curriculum. So the answer, David, is yes, all trainees will need to be assessed. The problem is, of course, is that all the consultants are not necessarily knowledgeable enough to train and to assess, and that's what we need to take forward. Also had issues about involving other specialties. How do we run NOTSS courses for other specialties? Now, I know, Jeremy, you've involved various other with you down in Preston. Have you got medical specialties on your courses, or are they just the surgical specialties?
Thank you, Simon. So far, it's just been surgical specialties, but we've covered the whole range of surgical specialties. We have in our own institution run team training for different groups, some of which are beyond surgery, both obs and gynae and interventional radiology. And we also been looking at gastroenterology, but that's within our own group. So I think, there's certainly a role for team training there and trying to push it out, especially for, as with things like, and I think there's a lot of recognition of the importance of that now, especially with the advent of NOTSS, national standards for interventional procedures and team working in those environments. I would agree with Mike's point that some specialties are quite difficult to attract to this kind of training. We found that I found similar things to Mike with regard to some of the surgical specialties in our area.
Okay, thank you very much. So got various issues about from the GMC. It's now a requirement, as we've said several times, to train trainees in various human factor skills. Mike, up in the northeast, I've got, and I know we had a gastroenterologist on one of the courses I came down and helped you with. Do you get other medical specialties coming to you, for example, interventional radiology, cardiology, gastroenterology, who would like to run similar courses, but obviously they aren't there?
Gastroenterology, certainly. So non-technical aspects in the endoscopy room are now embedded into the juniors training course, which is run once a year, again stymied by COVID. I haven't had approaches from radiology. Speaking to the head of School of Medicine, they have expressed interest from cardiology, but we've not taken that any further forward yet. It's something that we could do, but you don't want to overstretch yourself with a limited faculty.
You may be interested to know that we ran a NOTSS course for cardiologists, and it was run by George Youngson, who's from Aberdeen, and it was very successful with cardiology. And really, the interventional videos are very similar to what they would be in an ordinary theatre, perhaps with a laparoscopic theatre or so on. So I think there is a real role for developing this out into the other specialties. And we are due to speak to the Academy of Royal Colleges soon to see if we can develop some form of generic training course, and be interested to see what happens. We've had questions about what happens on a NOTSS course. Well, the simple answer is you come on one, and then you'll be able to see what happens. The other one is, how can I become faculty? It's very simple. You need to come on a NOTSS course, and then you need to training material, which we now have, and then you come on several courses as a facilitator, and then you become a member of faculty. So we're keen to have more members of faculty both around the UK and we're trying to underpin a lot of these training programs in various other countries. The question here is, how can you get on one of these training courses in Africa? Hands going up, they'd like to do that. So Steve, how do you bring your NOTSS course into Africa. What's the connections now in developing? And I know we had someone who actually emailed us today from Kenya about further developing NOTSS in other countries. What's your aim at the moment about developing these in sub-Saharan Africa?
Yeah, thanks, Simon. It's a great question. So we actually have a lot of partnerships. So last March, the college hosted a one-day meeting of surgeons and faculty from sub-Saharan Africa. So actually I've seen some of the questions here from WACS in the west, CASEXA in the east, PACS as well, different societies to think about how we could do this. We ran a one-day NOTSS course in Nigeria just at the start of this year. The key is to engage some faculty from those local regions, think about developing surgical videos. And actually we had the same discussion that we've had in other parts. So one of the discussions is, in Rwanda, could people from Malawi or neighboring Uganda come to a NOTSS course in Rwanda, or would we have to develop NOTSS Uganda, NOTSS Malawi? And I think that's a really important question about how generic are these skills. So we need to understand the context. We get the same questions about, can we run the Aberdeen NOTSS course in Glasgow? Is the culture so different between these two cities? And surely we need to take account of that. And sure, there's going to be some local things. So that's what the peer-to-peer learning brings out. So in short answer, you could email us. We're currently developing a strategy to enhance spread of these courses in sub-Saharan Africa. We've got a number of partners, and I think it would be, if people are interested, it'd be great to get in touch and let us know and help us make the connections.
Okay, thank you very much, Steve. I'm afraid we're running out of time. I'm able to answer any more questions, but to summarize, we're running a lot of trainee courses regionally, and these are becoming mandated for surgical trainees in all specialties. They're not mandated in every region, and clearly the deaneries will require support and to take these forward. With the guidelines and requirements from the GMC and the medical role, certainly in the UK, I think these courses are going to be mandatory. Now, we haven't got them in all the specialties, and we're going to be working towards developing them. So anybody involved or interested in being involved, please let me know. You can contact any of us through the College of Surgeons in Edinburgh. There's no doubt that team training will go forward, integrating everybody within the operating team. And the training courses we've run so far, which are half a day, have been very popular. Area that will expand, and anybody interested in getting involved in those. And of course, those are not just surgeons running the faculty, anaesthetists, scrub nurses, EPs, and so on. So I think there's a big issue about taking forward team training and how we develop it. Ken's description of his boot camp for CT1 and fantastic. And I think we have to look at how we integrate NOTSS training. And of course, the Vascular Society are ahead of the game with Aspire in how do we put our NOTSS training into a longitudinal program for all surgical specialties. Everybody listening, hopefully, is heavily involved in all this and will take it forward. And one question that came up, just to finish this off, is it's very difficult to involve NOTSS within the workplace if the consultants don't know anything about NOTSS. And some may be slightly resistant to this. And I think that's the case in any relatively new educational models. I think we all know that NOTSS works. We know that people with non-technical skill, good non-technical skills, not only become better surgeons, but their teams become better, outcomes become better, and the adverse events less. So I'd like to thank you all for taking part. Thank you for all the questions and the interactive discussion that we've had online. I'm sorry we can't answer everything. All the speakers, not only for joining us today, but for a huge amount of work that they have done over the last 10 or 15 years in developing NOTSS in the UK and increasingly overseas. And we've got a lot of centres overseas that many of you are actually online from. We have reached the tipping point in NOTSS, and it is now going forward with a much greater speed. And we can only do that with your help. So thank you to the speakers. Thank you to all the delegates. And we look forward to taking NOTSS forward into the future. Thank you all very much.